Hello, everyone, and welcome to today's webinar on narrowing racial gaps in breast cancer outcomes. My name is Lina Romero, and I'm one of the medical advisors at the Dr. Susan Love Foundation for Breast Cancer Research. For those of you joining us for the first time, I'd like to take this opportunity to introduce you to our organization. The Dr. Susan Love Foundation challenges the status quo to end breast cancer through innovative research and improve the lives of people impacted through education and advocacy. We drive collaborative, cutting-edge research with non-traditional partners and shed light on collateral damage of treatment and actively seek ways to diminish it, and interpret science to empower breast cancer patients. Many of the projects the foundation undertakes are designed to increase our understanding of the human breast, where breast cancer starts and what enables malignancy to occur, with the ultimate goal of developing methods to prevent it in the first place. The foundation is also committed to participation in research that has the potential to positively impact the lives of all people who are at risk for or who have breast cancer. Our Love Research Army, formerly known as the Army of Women, encourages and facilitates breast cancer research in all people, regardless of age, race, gender, or sexual identity, with or without a breast cancer diagnosis. We are also committed to thoughtfully engaging all of our members by providing them with ongoing, real-time access to an array of studies. Just a few logistics before we start. Today's webinar will be recorded, and our panelists will be available to answer your questions at the end of the webinar. So please submit your questions using the Q&A box on your screen and indicate if there's a specific person that you would like to direct your question to. While we will try to answer as many questions as possible, please note that we may not be able to address every question today. So with that, I would like to introduce our panelists. Ricky Fairley, breast cancer survivor and thriver, founder and CEO of Touch, the Black Breast Cancer Alliance. Jamil Rivers, breast cancer metavivor and thriver, founder and CEO of the Chrysalis Initiative. And Paris Thomas, breast cancer advocate and director of program operations at Equal Hope. Welcome, ladies, and thank you for joining us today. I'd like to start things off by having our panelists share their personal cancer stories and highlights of their careers as breast cancer advocates. Ricky, would you mind getting us started, please?
Sure, I knew I was gonna have to go first. So great to be here on this platform with these wonderful ladies and you, Lina. Thank you for having us. So I'm a 9-year survivor of triple negative breast cancer. I had stage 3A. I did a double mastectomy by choice and 6 rounds of chemo and 6 weeks of radiation. A year to the day of my diagnosis, they found 5 spots on my chest wall and basically said, you know, you're now metastatic, you know, get your affairs in order. You have 2 years. I said, no, you don't understand. I have a daughter in college. I have to pay for her to go to school. So you got to get me at least 2 more years. So to get my daughter to school. So me, you and God, we need some drugs. What have you got for me? And I went back on chemo and did 4 more rounds. And we went to put my implants in, and it's been 9 years and I'm here and I'm so blessed, walking in blessings to do this work. And I know that God left me here to do this work and to talk about and to be an advocate for breast cancer. So it's my purpose.
Ricky, that is such a compelling story and so nice to hear that you were in such a tough place back then. And now here you are, you've repurposed yourself in your mission to eradicate Black breast cancer. It's amazing. This reminds me of Jamil's story. Jamil, you too have reinvented yourself in your fight against cancer, which is reflected in the name of your breast cancer advocacy program, the Chrysalis Initiative. Would you kindly share your cancer journey with us?
Yes, thank you for having me, by the way, and including me on this important panel. I was the typical standard full-time executive, crazy busy, married mom of 3 boys, and had already gone through my husband's colon cancer journey. He was diagnosed with stage 1 colon cancer, and wintertime came, all of us got our colds, and my turn came and my cold didn't go away. So I went to the doctor, and after initially thinking they could prescribe me an antibiotic. That didn't work. Asthma pump didn't work. Finally asked for a chest scan and ultrasound just due to gallbladder and appendix issues running in my family. And come to find out, I have lesions already spread all over my body. No strong history in my family, and I didn't have the traditional lump. And so fast forward later, I now have metastatic stage 4 de novo from the start, hormone positive, HER2 negative breast cancer that had spread all over my body, except for my brain and my spine. And so I have been my husband's caregiver since 2009 with his colon cancer and liver transplant. And so I was really shocked. I had only started my new job 5 months prior. And so I really, I was devastated that first day, but I immediately thought of my family and my children. And I just thought, I've got to figure this thing out right away. And so I ended up working through chemotherapy. I did 1 year of chemotherapy. I also got involved with advocacy right away. I just felt like I had to learn as much as I possibly could, especially knowing the disparities impacting Black women. And so worked full-time during chemotherapy, also had the surgery to have my ovaries removed, and then finally reached no evidence of disease. And so it was amazing that I was able to get to that point, and I'm now on my second line of treatment, which is a CDK4/6 inhibitor and an aromatase inhibitor. And so on my journey, I ended up getting really involved with a ton of advocacy organizations and also mentoring other women along the way.
Wow, what a story. I mean, congratulations on being NED at this point, not having any evidence of disease. But your story as a mom, it really just breaks my heart.
Yeah.
I'm so moved, not only by your determination and will to live, to be here for your family, but that you had that generosity and eagerness to advocate for so many people whose lives have been turned upside down by this disease. So kudos to you, Jamil, and thank you for
Thank you.
everything you do. And Paris, you, like many of our viewers, have joined the club you never asked to be a part of with your mother who has a history of breast cancer. Can you please share your breast cancer connection with us?
Yes, thank you all for having me today. So in October, our family was getting ready to celebrate 10 years of my mom being cancer-free. I had just had a new infant, and we had found out that her cancer had came back and she was actually re-diagnosed with cancer. So my situation and navigation with breast cancer is a little different, being that I'm taking care of my mother. I'm navigating her through the system and taking care of her, making sure she gets everything she needs, and which is what brought me to this work and actually got me involved with Equal Hope here in Chicago.
I'm so sorry to hear that your mom has recurred and that you guys are back to battling breast cancer rather than celebrating her 10-year cancer-free anniversary. But she must feel blessed and proud to have you at her side, right? To help her navigate through this a second time.
Yeah.
You guys are such an incredible group of strong and motivated women. I'm so honored to share the screen with you today. Thank you for being here.
Thank you for
Thank
having
you.
me.
Thank you for having us.
So now to my cancer story. I'm a breast cancer surgeon, and I was diagnosed with axillary breast cancer, which means that it was found in my lymph nodes in my armpit rather than my breast. And this happened almost 7 years ago when my twins were 4. I'll never forget. I had my screening mammogram in between seeing patients in my breast clinic, and my heart sank when I saw the images. I just knew. And much like Jamil, my first thought was, I have to be here for my kids. It's not like I thought that as a breast cancer surgeon that I would somehow be spared breast cancer, but I did think that if I ever got it, it would be localized and we'd find it when it was in the breast, confined to the breast. But like many of you, I was shocked and fearful when I received that call. It was from my colleague that I worked with every day, and the biopsy was positive. Had it spread to my bone, my brain, or my liver and my lungs? Thankfully, it had not. So I underwent aggressive treatment with just about everything that you could have. And that lasted for about a year. And by the end of it, I was so physically and emotionally spent and completely estrogen depleted. I felt like I'd lost my superpower. One thing led to the next, and my priorities suddenly shifted. And after a few adjustments, I took down my shingle and I embraced my new title of soccer mom, at least for a while. But then as the pandemic drew on, I had much time to reflect, and the social unrest in the wake of the George Floyd murder and the surging COVID crisis, which, as you know, continues to disproportionately affect people of color, this really began to weigh on me. And it inspired me to pivot to find ways to use my unique perspective as a biracial breast cancer provider and survivor to advance health equity in vulnerable populations. This brought me to the foundation as it prioritizes health literacy and advocacy and inclusivity and diversity in research. I was further compelled to address the challenges of breast cancer mortality disparities after the loss of a dear friend to triple negative breast cancer during the pandemic. Nancy was a ray of light, a newlywed, and a grandmother, but sadly, she passed less than 18 months after her diagnosis. So, like for Jamil and Paris and Ricky, and for me, and many of you as well, I'm sure, this fight against breast cancer is personal on many levels. Let's go to the first slide. The underlying theme of this conversation is that knowledge is power, which Maya Angelou states so eloquently with her quote, "When you know better, you do better." This talk about narrowing racial gaps in breast cancer mortality is going to be divided into 3 parts. First, I'll share some background information and describe the gravity of the problem and how it can be remedied. The second part will be a meaningful conversation with Paris, Jamil, and Ricky, our extraordinary cancer thrivers and advocates. And my hope is that you will find it relatable because either you or someone you love has been there. And for those of you that have not experienced breast cancer or the disparities that we'll be discussing, perhaps it will be an opportunity to develop a better understanding of the barriers that many people of color face when battling cancer. The third part of the webinar will be a Q&A session with our viewers. And my hope is that you will leave this webinar knowing better and doing better. In order to address the problem of racial disparities in breast cancer death rates, we must start by acknowledging the problem and quantifying the disparities. Then we must determine the cause of the problem by gaining an understanding of the barriers to health equity. And then finally, armed with the causes, we can begin to work on the solution by taking actions that will drive health equity. So let's start with the first objective, defining the problem. Black women are 42% more likely to die of breast cancer than their white counterparts in this country nationwide. They are often diagnosed at a younger age and at a later stage, and are twice as likely to have triple negative breast cancer, an aggressive cancer subtype. If you look at this graph, the red line represents breast cancer mortality in Black women, while the gray line represents breast cancer mortality in white women. You can see that in the 80s, there was no mortality disparity, meaning that the death rate from breast cancer was similar for Black and white women. In the 90s, as screening mammography increased and treatments became better, survival rates began to increase for white women. But unfortunately, this improvement in survival did not extend to Black women, as noted by the red curve. So now that we've defined the problem, that there is a mortality disparity, we can focus on our second objective, which is understanding why these disparities exist. We know that the barriers to breast cancer health equity are multifactorial. And a good way to break this down, I think, is to classify the factors that contribute to disparities into 2 categories, intrinsic factors and extrinsic factors. Intrinsic factors include genetic or biologic factors. Then pretty much everything else is an extrinsic factor, or I like to think of them as man-made barriers. These include patient factors, such as personal habits, provider factors, such as the quality of care delivered, the provider experience, implicit bias or stereotypes, if you will. And let me talk about implicit bias for a minute. It's important because it can lead to a communication failure between a medical provider and a minority patient. And it can include failing to properly explain or even offer certain diagnostic or treatment options to patients. For instance, a study like a breast MRI that is often used to rule out, to make sure there are no additional lesions in the breast or the opposite breast prior to formalizing a surgery plan, that test might not be offered to every patient the way to more vulnerable patients the way they might be offered to their white counterparts. Implicit bias is also known to limit Black inclusion in clinical trials, as evidenced by many Black women that have been surveyed saying that clinical trials were simply never offered to them. There are also psychosocial and cultural factors, such as the stigma associated with breast cancer and not wanting to talk about it. And then, of course, there are socioeconomic factors, like where one lives, what type of insurance one has, and one's level of income. Finally, there are systemic factors such as quality healthcare delivery barriers and structural or systemic racism. Not all of these factors are tangible or well understood. For instance, many people cannot imagine skipping something as important as chemotherapy, but perhaps a single mom that needs to go to work to put food on that table would have to make that hard choice. Next, I'll play a video about health equity. The point of the video is to help us understand some of the struggles that people of color may face when they're ill. Let's go to the video.
My grandmother tells a story of hospitals in her day. One of barriers, one of trauma, one of fear. When we are sick, she pulls remedies from a tattered notebook, recipes passed through generations of those misunderstood by the world around them. She ensures this cold, this ache, this fever will break by morning. All we need is this prayer, this herb, this belief that better days are coming. She doesn't speak of bad health. She says with stern eyes, only speak life. A lesson, a warning, and a hope in one. Packaged words birthed from a time when healthcare didn't look like help for us. I feel this chill down my spine when I am ill. When my only option left is a doctor's office or the never-ending maze of a hospital. The fear that there will be assumptions about who I am, that things will be ignored like culture and beliefs, that I won't be heard, that history repeats itself. Fear that these hallways will be the same broken roads instead of bridges to new understanding. I envy those who don't have to sit with crossed fingers hoping. Envy their peace of mind and comfort. All anyone wants is to be understood, to be heard, to be told that help is actually on the way.
Can anyone Can anyone relate to that? From the video, you can see that for many people of color, the thought of seeking medical attention comes only as a last resort. And this is due to the worry that they may be faced with a multitude of barriers or assumptions, and that their best interests may not be taken into account. Essentially, it boils down to a matter of trust. And this lack of trust is clearly a health equity barrier. Let me briefly present a case that was published in the New England Journal of Medicine to further illustrate this point. Mrs. M is a 60-year-old female who is unemployed and uninsured, and she presented to a community hospital in Chicago with a breast lump in 2015. She was given antibiotics for a presumed infection with no further workup. The mass persisted, so she thankfully got a mammogram, and it did reveal a suspicious lesion. Instead of undergoing a needle biopsy, which is the indicated and standard way that a breast cancer at this point should be diagnosed, a general surgeon performed an open biopsy in the operating room, and that revealed cancer. After her surgery, a mastectomy with removal of lymph nodes in her armpit was recommended, and no further options were discussed. As serendipity would have it, she was then contacted by a navigator from the Metropolitan Chicago Breast Cancer Task Force and referred to a breast surgical oncologist who told her that a lumpectomy was also a treatment option. She was grateful they intervened just in time to stop her from, as she said, having her breast cut off. Again, this story of gross mismanagement happened in 2015. This wasn't 20 years ago, and it was in a big city of Chicago. So I think that we should know better and we need to do better. So let's identify some of the barriers to breast cancer health equity. Much work has been done in various cities to identify local barriers to quality care in an effort to find solutions to narrow the divide. The Boston Breast Cancer Coalition studied barriers to quality breast cancer care and found that screening mammography and delays in diagnosis were not barriers in Boston. But as Paris will tell us more, they were in Chicago. Instead, in Boston, they found that women experienced lower treatment rates than their white counterparts, experienced more delays in initiating and completing their care, and were less likely to adhere to or complete their full treatment regimen. We'll talk more about the barriers in Chicago and Philadelphia with Paris and Jamil during the discussion. What's important to note is that when we fail to deliver quality care in underserved communities, we have a problem with our healthcare delivery system and our public health policies. Examples of systemic problems include things like outdated mammography machines, unavailable qualified radiologists to read patients' imaging. Paris actually shared a story with me about a facility where there was a binder full of patients that had not been called back after they had an abnormal screening mammogram because everyone in that clinic was so overworked, there was no one willing to make those calls. Meanwhile, the patients were literally sitting on their cancers with no clue that the imaging had been abnormal. Dr. Ansel, the co-founder of the Chicago Breast Cancer Task Force, argues that because mortality rates for Blacks and whites were similar in the 80s, as we saw in that graph earlier, that Black women's genes, though perhaps a factor in driving disparities in outcomes, were not the determinant or the biggest factor in the mortality disparity in Chicago specifically. He went on to say, if the rates at which African-American women are dying today is substantially higher than in the 80s, it suggests that the cause that is driving this increased disparity is racism and not race or biology. Another way of looking at it is to say that cancer injustice is not a science problem, it's not a technology problem or a genetics problem, but a policy problem. And to be clear, this is not to say that biology plays no role in driving disparities. But what it does say is that in Boston, when systems were changed and extrinsic or man-made barriers were removed to the completion of treatment, the mortality disparity decreased. We must continue dismantling these extrinsic or man-made hurdles to further reduce breast cancer health inequities. I like to think of it as leveling the playing field. Let's all start at the same level. So we will address the issue of barriers and biology further in our panel with Ricky. In the meantime, extrinsic barriers such as poor healthcare delivery systems, provider implicit bias, and the historical abuse of Black Americans in the medical system have resulted in an understandable lack of trust in the medical profession by people of color. Let's watch this video to see an example that may shed further light on the source of this distrust.
Trying to understand a historical problem without knowing its history is like trying to treat a patient without eliciting a thorough medical history. You're doomed to failure.
That's Harriet Washington, a medical ethicist and author who chronicled the intersection of race and medicine in her book, Medical Apartheid. While many of the stark racial disparities in healthcare can be attributed to environmental and economic factors like access to good healthcare, studies show that minority patients tend to receive a lower quality of care than non-minorities, even when they have the same types of health insurance or the same ability to pay for care.
As African Americans, we've been abused for so long, consistently by the system. Why should we trust it? Why should we go to it when ill? And that's iatrophobia. That's a fear of the healer, inculcated by the behavior of those healers, unfortunately.
So there's even a word for the fear of doctors that some people of color and others feel, and that's iatrophobia. This brings us to another barrier that remains to be addressed, which is the fact that Black people are significantly underrepresented in clinical trials in the United States. The graph on the left shows that the significant lack of inclusion of Black people in FDA trials. As you can see, with Black participation being represented by the yellow line all the way at the bottom of the graph. The image on the right shows the percentage of Caucasians represented in clinical trials, and that it matches 77%, the percentage of Caucasians in the population. But this is not the case for Black Americans who are underrepresented in clinical trials. As you can see, 13% of the population is Black, but only 7% of clinical trial participants are Black. Appropriate representation in research is so important because it ensures that the knowledge that we gain from the studies can be applied to that particular group. This lack of Black inclusion in clinical trials is yet another example of a complex systemic and cultural barrier that we must overcome to improve breast cancer mortality rates. Let's watch a short clip that shows an example of how historical treatment of Black bodies in research has eroded trust in the medical system and continues to dampen participation in clinical trials to this day. Let's go to the video.
In the infamous Tuskegee experiment, federal researchers observed 399 Black men with syphilis from 1932 to 1972. A cure was discovered 13 years in, but doctors withheld treatment for decades just so they could continue their work. And that's not even the most egregious example.
So this video speaks for itself. As the reporter said at the end of the clip, this is just one of many, many examples. Next slide. Let's skip this slide in the interest of time. Okay, so now we're going to discuss our third objective. How do we solve the problem of racial mortality disparities in breast cancer and drive health equity? In Boston, they looked at local factors and showed that the disparities in Boston were the result of problems with adherence to treatment regimens. So given that treatment was the problem, they used this data, and the Boston Breast Cancer Coalition focused specifically on improving compliance with treatment. They developed best practice models aimed at reducing time from diagnosis to completion of treatment, and were successful in improving the timely completion of treatment. And this was largely as a result of the use of culturally sensitive navigation programs, which we'll talk about more with the panel. This bar graph illustrates the impressive work that Paris's group, Equal Hope, did in Chicago. The graphic shows changes in breast cancer survival from the time period between 1999 to 2005, compared with the time period from 2006 to 2013, divided by city. Again, we see significant geographic variability in mortality disparities, with Chicago leading the way, and by improving survival in Black women. Philadelphia is second on this graph. But you can see that Houston, Los Angeles, and Memphis saw disparities increase during this time. The narrowing of breast cancer mortality disparities in cities like Chicago and Philadelphia that were achieved by eliminating extrinsic barriers to quality care, this shows that racial disparities are not inevitable. It's not the patient's fault. And that we can use such mortality gap, but we can narrow such mortality gaps by using collaborative commitment and resources. Because of this success, a commitment to data-driven improvements in healthcare delivery systems should be an essential public health goal. So to summarize, in order to solve the complex problem of breast cancer mortality disparities, first, we must identify the weaknesses responsible for the disparities. Then we must implement targeted interventions that are culturally sensitive, community outreach, and patient education. I can't overemphasize the importance of patient education and health literacy, that knowledge is power. We must not only provide patient education, but also provider education to reduce implicit biases. And we must provide culturally sensitive navigation. We must push our local health officials for funding and legislative changes that promote equity. And last but not least, we must identify and dismantle all barriers to Black inclusion in clinical trials so that the knowledge gained is applicable to Black people with breast cancer. The reason to address these existing racial mortality disparities was poignantly stated by Dr. Martin Luther King, who said, "Of all forms of inequality, injustice in health is the most shocking and the most inhuman. These disparities matter not in their numbers, but in the effect that they may have on vulnerable people touched by cancer, including families who will have an empty chair at the table this Christmas. This is especially devastating if their death was preventable. Each death is one death too many." So in conclusion, we've acknowledged the problem of 42% mortality disparity between Black and white women with breast cancer nationwide. We know some of the reasons why the problems exist and have learned that these barriers to equity are multifactorial and they vary by geography. They can be intrinsic, such as biologic factors, or extrinsic. And most importantly, we know how to solve the problem. To do so, we must educate, navigate, legislate, and advocate. To allow these disparities to persist is an abdication of our social obligation if healthcare is a right. So we are tasked with continuing to address the problem. We must commit to continue to remove the extrinsic barriers until breast cancer mortality disparities are eliminated as much as possible, and to study the biologic ones until breast cancer is eradicated. It's time. We know better, so let's do better. Okay, so we'll go off the slides and to the panel for the fun part. I am going to ask some questions, and if it's not asked directly of you, but you have something to add, please feel free to join in. So we'll start with a question for all of you. If you could please each tell me your personal experience with barriers as you or your loved one went from diagnosis through treatment of your breast cancer, including any examples of implicit bias. And if you did not have such experiences, then why do you think your experience was different than so many others? Let's start with Jamil.
So mine was a combination. I am treated at one of those large university type centers that's associated with NCI and NCCN. And I noticed that it depended on what I was seeking out. So I did notice that I was not provided with clinical trial information initially. I did have to be assertive and inquire about that information. As far as all of the supportive services and resources available to me as a patient at the center, I also had to seek those out individually with each office as well. That wasn't initially presented to me as part of my care. Also, I opted to have surgery to have my ovaries removed. That wasn't an option that was initially presented for me. And it took some advocacy personally on my part for about a month to really push that I needed to get this done because I knew that my breast cancer is hormone positive. I didn't want it to have this ongoing supply of hormones, so I really wanted to shut it down. And they just said, well, this is not typically a surgery that we do in metastatic patients, but I knew that I was going to be in treatment for the rest of my life. And so I really wanted to have a more durable response based off of my own personal research that the best way to have that done would be to get the surgery. And so after a month, they finally agreed to have that done. So that took some personal advocacy on my part. So those were some of the individual on a personal level that I encountered with my breast cancer care.
And good for you for advocating for yourself, because I agree, you know, sometimes as providers, we go, okay, well, if it's metastatic, like we don't do breast surgery, we don't remove the primary, we don't remove liver mets, we don't do this, we don't do that. But of course, you came up with a great option, which was let's get rid of my ovaries, because that way we can shut down that estrogen as much as possible. So, but it is disappointing to hear that someone your age that was healthy, that was diagnosed with stage 4 cancer, was not given information about clinical trials. That's, you know, at a good institution, at a good,
Right.
So it just points to the fact that if you hadn't been at a good institution, then imagine what the cure might have been, right? So
Exactly.
yeah. So what about you, Ricky? Did you have any experience?
So of course Harper starts barking as soon as I talk. Go off
My
and
dogs
mute.
do that too, so don't worry. All used to it.
So, you know, I didn't really experience too much implicit racism, but I had triple negative, and it was 9 years ago now. My doctor at the time was very young. She was 38, and she had only had 2 cases of triple negative before me, and both of the women died in 9 months. So her bias was to tell me I was going to die, you know, because that was her personal experience with triple negative. And I remember thinking, okay, you know, triple negative, like, why don't we have a drug? Why are we the only breast cancer without a drug to prevent recurrence? Is it because Black women get it? Is it because, you know, the mortality rate's so high? So I did remember thinking, there's got to be some injustice in the treatment of triple negative breast cancer, because there are no options. And since that time, thank you God, we now have 3 really good options for metastatic triple negative. But you know, 9 years ago, there weren't any options. Actually, 4 years ago, there weren't any options. And so I think that just the state of that disease has come a long way in terms of getting attention. But I do believe there was some racial bias and why it wasn't getting attention for many years, because Black women were dying.
That makes sense. That makes sense. And again, it's trying to find things that we know how to fix. Oh, we can give you letrozole because you're hormone positive. We can give you a Arimidex. We can give you, but oh, we don't have anything to give you, so we're not even going to talk about that, right? That is a problem with the medical system.
Well, frankly, also the first real study of the national impact of triple negative on Black women was just conducted 1.5 years ago by Leah Scott, University of Georgia. But until then, we didn't even have data about the impact of triple negative. We didn't have it quantified on Black women. And now we know it's 2.3 times the rate, but no one had even done a study of us
to look at
it for many years. Yeah.
And we say knowledge is power. You need to know what the problem is if you want to fix it.
Yes.
So Paris, what about you as you navigated the system? Well, she had her built-in navigator, so maybe everything went perfectly. But what experiences have you seen more on the personal level? Then we'll talk a little bit in a minute about on the kind of navigator side.
Yeah, so personal level, just thinking about my mother, I think we had more healthcare barriers and a little bit of, you know, fragmentation. So my mother is a veteran, and she prefers to always get her care at the VA. At the time, 10 years ago, the VA now is no longer doing breast, and they contract out, but before they were doing chemo and radiation and basically taking care of the spot. But what we found out as we were now 10 years later moved to a comprehensive care center, that her cancer was actually not fully out. There was still some left over, which is why she had a reoccurrence. So we saw a barrier there, and we do understand that with the VA, she felt more comfortable. And even this time with her second round of going through cancer, she'd rather be at the VA than the comprehensive care center, because she's like, they take care of me. There's not a lot of women. They treat me like a princess there. I'm like, that's great and everything, but it involves a lot of education. And I think we run into that a lot with a lot of women. You get comfortable in the facility that you know and the people that treat you right, but there may be another facility that can give you better outcomes. But she'd rather just be at the VA. But we do have her in a comprehensive care center that can do a lot for her. But even in that center, she feels very small and like she's overlooked and like she's just a number. So that was really the biggest barrier running. So we haven't had a lot of implicit bias. She has great surgeons and oncologists now. And so we're just hopeful this time that we will beat it.
it's such a dichotomy, right? That you know that the academic center is helping her, but that even knowing what happened, she's still having a hard time accepting that. And so it just goes to show that feeling like you belong and feeling like you're a part of something is important. And we need to do better at making everyone feel like you go to the hospital, and that everyone should be able to go to a hospital and feel like
Right.
I'm here and everyone's here to take care of me, regardless of my skin color or, you know, whatever, my sexual identity or whatever it is. And it's a shame that even with you, who is so well versed in this, that your mother is still feeling these things. So hopefully we can make some improvements in that with more advocacy. Paris, let's hear a little bit about the different roles that the Quality Consortium, the Chicago Quality Consortium, and the Chicago Metropolitan Breast Cancer Task Force did to collaborate, and how that made your program a little bit different than some of the other breast advocacy programs.
Yes, so 10 years ago here in Chicago, we were founded by two physicians that saw that the mortality rate for African-American women here in Chicago was much higher than the national average. It's set at 62%. They then convened a task force of all of Chicago's radiologists, oncologists, surgeons, and breast experts together to basically have a meeting to discuss what we could do about those barriers. So as all of those professionals met, they came up with three basically entities that were the problem here in Chicago. There was unequal access to mammography, unequal quality of mammography, unequal quality and access to treatment. And so our quality consortium is basically our data arm, and it drives everything that we do. And so we started working with multiple hospitals here in Chicago to collect their quality mammography data to see where certain facilities stood versus other ones. And obviously your comprehensive care centers and those that are accredited at the top, but we have other facilities like safety net hospitals that are kind of varying and don't have the best radiologists or the best mammography machines or have their own barriers. And so within that work then informed our navigation work and our policy work. So we have three arms, and then our navigation programs came into play, where we're actually navigating women through the system and not just educating and navigating, getting them their quality mammography, diagnosis, and then to treatment. Our policy arm as well, it kind of drives the legislation that we advocate for that year. We go down to Springfield or our capital every year, and we have our Fierce Women in Pink, and they go down and they kind of make a roar and go find their representatives and tell them to get things on the map. So that's kind of how our system works with Equal Hope.
And so I just wanted to highlight that, because I think that what you said is that your navigation was informed, your legislation was informed, even your education is informed. And so, you know, sometimes we like to, okay, well, Chicago did it this way, so we're going to do the same thing. But unless you know what the problem that you're trying to solve is, you might be, you know, barking up the wrong tree. And so I think that it's commendable and a great way to approach things. Jamil, tell me a little bit. I know that Adhere in Philadelphia has done similar things. Tell me a little bit about what you think the barriers to health equity in Philadelphia are and how they've been addressed, because those disparities were nicely narrowed there as well.
So historically, a lot of our disparities and inequities were addressed by the Medicaid expansion. We have the federal program, which we call in Pennsylvania Healthy Women program, which eliminated those wait times, covered, of course, the preventative mammograms for that initial screening was covered by the ACA, but the diagnostic tests and the coverage for care was also covered by the Healthy Women PA program. So that eliminated a lot of the treatment barriers, cost barriers, and things like that that would delay care, and also would result in just women not having the resource available to have their breast cancer diagnosed and treated with the best care available. So we eliminated a lot of those waiting periods and delays as far as just eligibility concerns and things like that. We still do have a number of waiting periods just due to Medicare eligibility, or sometimes there is a waiting period, but we are able to expedite people right away to get that care initially without a lot of the income verification and things like that. That was a challenge in the past. And then recently, it was definitely a multi organizational effort. So working with nonprofit organizations, the hospitals themselves, our local congressional leaders as far as what the actual problem is. And we had a really evidence-based, data-driven strategy. So for a long time, traditionally, most of the resources available were covering transportation and the coverage of mammograms. With the most recent studies that we were doing that analysis, we found that with the Medicaid expansion, there was only really a 2% gap as far as the, coverage, cost coverage and treatment not being covered or the cover for that initial screening. The problem was the diagnostic screenings and the diagnostic workup and treatment delays, which was also caused by provider bias and implicit bias and some of the structural challenges where without those standard processes across the board within these various centers, you would have providers functioning as gatekeepers in a sense, where genetic testing, genomic testing wasn't offered to Black patients. There was typically a delay in that initial presentation of symptoms and that diagnostic workup, and then how long it would take them to get their appointments and treatments and appointments scheduled thereafter. It was a persistent issue ongoing. And so having that intervention with immediate coverage of those costs so that those copays that are pretty exorbitant of being $250 to $1,000 were covered. And then also making sure that there were processes in place, just standard across the board. We were able to really push for that in Philadelphia and some of the other local suburban areas for those centers that are associated with NCCN and NCI. With that accreditation to start having equity audits within their centers to see like, okay, if your white patient presented with symptoms and was, then able to get screened and have that diagnostic workup and treatment right away in comparison to Black women who are being diagnosed younger or presenting with symptoms younger and then being turned away and then coming back later now that it's progressed, or if they are brought in, that diagnostic workup and that follow-up and treatment is delayed even further. We also found that the majority of Black women are single, and the ones that were the least compliant with their cancer care were under the age of 60. And so in Pennsylvania, there are a lot of supports already available for women over the age of 60 if there is a cost or treatment issue, but women that were under the age of 60 lacking that PTO time in order to just take off, having challenges with being eligible for some of those, other reinforcements to cover those costs was also a challenge as well. So being able to have that specific data to identify that and say, these are the issues, and being able to provide the resources into those areas where the disparities were prevalent. And then aftercare, we found that a lot of times that support to keep people in treatment was not provided to Black women as often as their white counterparts. We found that the most important thing is to focus on the treatment itself, similar to Boston, where whatever the barrier is that's impeding that patient to staying within treatment and getting that care, that's what should be addressed. And then post-treatment, we found that Black women were not followed up and receiving that monitoring as much as possible or having support in order to get those follow-up tests and screenings after their breast cancer care to make sure that they understood what to look out for and then also what tests and screenings they needed to have done after the fact in order to stay on that quality continuum of care.
So it sounds like, again, like in Chicago and like in Boston, specific barriers were identified, and therefore the solutions were able to be more targeted, which sounds great. I think you make a good point about the younger people not having as many resources as the older people. And sometimes the younger people are the ones with the most scattered lives, with the kids, with the work. And so it's good that that was brought out as well. So let's turn to Ricky now. And Ricky, we know that breast cancer barriers are multifactorial and that they vary by geography, but your focus with Touch is on clinical research trials. So tell us a little bit about that and what you think is driving disparities based on that you're involved in.
Brian, I know some of the history says that it may not be biological, but the statistics for Black women are just so devastating that I believe there has to be something biological. I believe there's a gene panel that we haven't figured out yet. There's, gene mutations we haven't figured out, that just for Black women in general, but also for triple negative. And I think because of the lack of participation in clinical trial research, we don't really know. We don't really know that Black women have different bodies or different physiology because we've never been tested. So our work is really to try to figure out what are those differences. Is there something there? When you start thinking about the 42% higher mortality rate, that Black women under 35 get breast cancer at twice the rate, die at 3 times the rate, that we have a 39% higher recurrence rate. Those numbers have to be have to mean something. And I clearly, the psychosocial factors are a huge part of it. But I really believe we need to uncover the biology of Black women and unpack that data and understand our bodies better to make drugs that could be different for us, or different dosing for us, or, and I think we have to figure that out. So we're working really hard to figure out how to do a better job recruiting Black women for clinical trials, because right now it's a fail. And I think that what we're doing is we are very proud and in control, helicopter moms, helicopter grandmas. And when you take us out of our strong house and environment where we'll do anything for the people we love, drive us across town to a facility where we don't see anybody that looks like us, and you want to stick a needle in my arm of something that you don't know about, I don't think so. So we're stripping of her power and her control and putting her into a position of total vulnerability. And until we figure out how to message that better and help her feel in control of that scientific environment and want to do the work, we're gonna continue to fail. So I have 10 years before my grandbabies get boobs. They're 1 and 3, and they're my purpose. And I don't want them to ever speak the words breast cancer. So we don't have a lot of time to work on this, but I really want to undo the science, figure out the science.
And that's so commendable. I know that you recently were granted or received 2 grants to look into the barriers and the barriers to Black inclusion in clinical trials, and to look at the marketing of how to improve inclusion into clinical trials for Black people. And so congratulations on that.
Thank you. And we're excited to do that work. Yeah.
At this point, we're going to turn to some of the questions from the audience. And unless they specifically address it to one of the panelists, then you can, well, maybe I'll direct who we'd like to ask. Paris, in terms of navigation, what were the keys to a successful navigation program?
Yeah, so the key to a successful navigation program here in Chicago had a lot to do with mapping. Before we created our navigation program, we had to understand where our need was. So we saw that in the west and south side of Chicago. We then went into those communities and we got navigators who are actually from those communities, because we believe that in order to navigate women from those facilities, you need to be able to look like them and talk like them and understand the community. So we believe in a culturally competent program. So all of our navigators are actually from the same communities we're navigating from, and we're able to actually educate and meet people where they are. And I think the difference between our program and other programs is that there's a lot of navigators, there's a lot of care coordinators, but they're hospital driven and they're system driven. We're community driven. So we're actually in the community. We're going into barbershops and beauty salons and nail salons and talking to you like we're just your girlfriend, and trying to educate you and basically get you into the system to want to get a screening and to even follow up and do additional things. So that's really how our program kind of works. And we build trust so that we can get the patients where they need to be.
And again, excellent point, that if you have someone that sounds like you and that looks like you, you're more willing to listen to them. And, it's not the case for people that or perhaps not everyone needs that kind of care, but I think a lot of people do. And so we've identified that as a barrier, and it's good that we've developed navigation systems that work around that. Someone in the audience wanted to know if you could share the name of the triple negative study again. And I think maybe they're referring to you, Ricky.
Sure. Yeah, the study was done by Leah Scott at University of Georgia, and it came out, I want to say last spring, so it's not quite a year and a half ago. But she's now at Emory. But if you just Google Leah Scott and triple negative breast cancer, you'll find the study. LIA, Leah Scott, and she had a team, but she was a grad student, I believe, at University of Georgia. She's now a PhD at Emory.
There's a question about what about environmental pollutant factors? Certainly Black women may live in disproportionately higher polluted areas. Do any of you want to take a gander at that one? Jamil.
Oh, sure. So it is true that we are more at risk because of the toxicity in a lot of the environments that we live in, just due to socioeconomic issues. But as far as the correlation, it is still fairly low as far as the causal factor for environmental impact. But of course, just the consolidation of all of these factors together can increase our risk overall.
Can't really separate a lot of the factors, but I think you have to kind of look at them as a gestalt. But I think we have to try to unpack them as much as we can so we could solve for them.
Right.
One by one,
We have a question from the viewers. I know there is at least one genetic mutation that that goes back to the western coast of Africa and increases risk. How much genetic research has been done? Ricky, I know this is something that you've been working on.
Yes, so Dr. Lisa Newman and her lab is run by Dr. Melissa Davis at Weill Cornell. They've done extensive research in Africa and in other, other areas of the world on Black women, specifically around the BRCA gene, So I think they are finding some stuff up. There's actually another study that just came out recently from University of Virginia about triple negative. So there's some work being done, but not enough. Yeah. And I think, I don't want to discredit anything that's been done, but I think we need to go even just beyond BRCA to look at if there are other mutations that aren't necessarily BRCA related. But they've done some really phenomenal work on triple negative in the Caribbean and in Africa. Dr. Lisa Newman and Melissa Davis.
And so yeah, that's a great point, that we focus on the BRCA genes, but there are undoubtedly other genes that are important as well. And so again, we have to ask that question to find that answer.
Right. Or we may not have even identified the genes yet.
Right.
That's very true. Yes.
Yeah. I don't think we know. Yeah.
Participating, here's another one. Participating in a clinical trial seems daunting. Do you have any advice for someone who's seeking a clinical trial?
Can I answer that one?
Oh, okay.
I think what's daunting is getting into it. It's so difficult to do the paperwork to find the trial, and there's lots of ways to do that. And you can talk to me offline. I can help you with that. But at the end of the day, you get better care. You get more scans. You get more closer attention. In most situations, they're paid for. You don't have to pay for the cost of it. You don't have to pay for transportation and kind of the logistics of getting the treatment. And you're really watched a lot more closely. And the way I kind of my Band-Aid until we kind of figure out what the messaging needs to be is, you may not want to do it for yourself, but do it for your daughter, do it for your granddaughter, do it for your kids, do it for your son, do it for somebody else, and take the risks that you think are there, and try to figure out the science, because it's so important. But you're gonna because of all the bad stuff that happened in our history, all the laws have changed, all the rules have changed, and you are now almost in a very coddled environment to be in a clinical trial. You're getting a really good high standard of care, and you're being watched over very closely. So it shouldn't be something to be feared. It should be something to be embraced.
Thank you for that. Unfortunately, we're already out of time for today. So I'd like to give a big thank you to Ricky, Jamil, and Paris for their participation, and for you, the audience, for joining us. If you have any questions that weren't answered today, or would like to get in touch with the Foundation about the Love Research Army or any of the research initiatives, please email info@drsusanloveresearch.org. Today's webinar has been recorded and will soon be posted to our website, which is linked in the chat box for your convenience. I also encourage you to visit our website if you're interested in learning about the foundation or making a donation in support of research. In closing, I'd like to thank each of you, our panelists, again for joining us today and for all that you give in our vision to eradicate breast cancer. I look forward to collaborating with you again in the near future. May you all have a safe and healthy holiday season. Thank you.
Thank
Thank
you.
you. Thank you. Thanks for having
Bye,
us.
everyone.
Thank you. Bye.
Bye.